Okay, welcome everybody. I've got a great pleasure to have both Michelle Pensabranco and Jodine Chase from SafelyFed Canada here to present on infant feeding considerations related to the COVID-19 pandemic. I'd like to introduce Michelle and Jodine. Michelle is an international board certified lactation consultant and public health advocate. In addition to her clinical practice, which includes both in-hospital, outpatient and private practice settings, she advocates for improving maternal child health practices at the local, national and global levels. She has a particular interest in the impact of trauma to breastfeeding families, models of peer support to improve breastfeeding outcomes, and the application of health communication principles to the promotion and protection of breastfeeding. Michelle serves as the clinical leader for SafelyFed Canada. Jodine Chase is a public relations and communications consultant specializing in issues and clinical management, news and analysis. She is currently enrolled in a Master's of Arts program at Royal Roads, specializing in intercultural and international communication and disaster and emergency management. Along with her co-lead, Michelle, who has her Master's in Public Health, Jodine founded SafelyFed Canada, which is a national non-profit, non-partisan organization dedicated to the protection of infants and young children in emergencies through safe and appropriate feeding. SafelyFed Canada advocates for improving infant feeding policy federally, provincially and locally, designs and delivers training and coordinates direct aid to families in emergencies through their staff, volunteers and partner organizations. I'd like to welcome you both, Michelle and Jodine, and we really look forward to hearing your presentation. Thank you.
Thank you, Carol, for that introduction. So I will go on to note that we have no conflicts to declare, that SafelyFed Canada does not accept funding from those who manufacture, distribute, or market infant feeding-related products, or who are not at arm's length from such entities, and that we are explicitly committed to upholding the International Code of Marketing of Breast Milk Substitutes, the Infant Feeding in Emergencies Ops Guidance, Operations Guidance, and the SPHERE Guidelines. Our agenda for today, we'll be introducing our audience to the principles of emergency response and infant and young child feeding in emergencies. We'll review what we know about COVID-19. We will speak about the implications of that for programming, practice, and communications. We'll be exploring available resources for healthcare workers in the lactation field, in the IYCF field, and we will be looking also at where we have some information and resource gaps, and we will be addressing questions. So I will begin in talking about the principles portion of our presentation. So in general, in emergency preparedness, it's important to consider that every emergency is unique and that the response is shaped by the characteristics and the needs of the community that is impacted by the emergency or the disaster. And that, of course, we do know, and it's important to consider here, that low-income families, racialized newcomer and single-parent households are less likely to be prepared in advance of an emergency. It is very helpful for those who are tasked with both planning and responding to have access to reliable and detailed infant feeding data and also general demographic data. It's important for us to know how many infants there are who are breastfeeding, mixed feeding, feeding breast milk and other substances such as infant formula, and how many fully infant formula fed infants there are within a population. In this particular circumstance, we note that the amount of time that we are being asked to prepare for disruption is 2 to 4 weeks, and that's considerably longer than the usual recommendations to be prepared for 72 hours, and that's North American guidance. So there is good information from the Crisis and Emergency Risk Communication Division of the U.S. Center for Disease Control. And this slide is up here to help us just focus on the life cycle of disasters. This is the CIRC model and where we are, of course, in this particular disaster. So in any disaster, we first begin by talking about planning in advance of the disaster, and then we have the crisis event, which is where we are right now. There's a period after response where we shift over to away from a direct immediate response and into secondary responses with a focus on maintaining the situation to make sure that it does not worsen, and then we move into recovery. And then at the end of that, the circular process is that we evaluate how we did, whether or not our response actually matched our plan, and then we take that increased awareness and turn it back into a new planning, updating and making sure that our plans are appropriate. So that is important to consider whenever you're working in the midst of a disaster, that you know that your plans may not be as good as you had thought, and always be keeping an eye out for opportunities to evaluate, knowing that you're going to be updating your plan once you get through the crisis. So specific to infant feeding and emergencies, we know that infants and young children and also pregnant and lactating people are at increased risk in emergencies. So they are a vulnerable population. We also know, and it's important to remember, that breastfeeding is protective against many of the risks that infants and young children face, both generally but specifically in emergency. And in particular, there's always a higher rate of respiratory and gastrointestinal illness in emergencies, and breastfeeding is naturally protective against those illnesses. And feeding practices are often, in fact, virtually always eroded during emergencies. And we know that once those feeding practices are eroded, they do not return to whatever the community's baseline was during recovery. And sometimes that lack of return can impact a community for many years after a large disaster. There is operations guidance that has been developed and was recently updated. The guidance is housed with the Emergency Nutrition Network. The Infant Feeding and Emergencies Core Group works on the guidance, and the current version is version 3.0. It is available in a number of languages, and the guidance focuses around 6 actions. So the need to ensure that policies are developed or are endorsed so that they are taken seriously by organizations that are responding, to train staff, to coordinate operations, to make sure that infant and young child feeding is part of the operational response, to assess the situation and to monitor progress. And the need, of course, is to protect, promote, and support optimal infant and young child feeding. And so what we're saying is that the global guidance, the general global guidance, the global strategy for infant and young child feeding needs to be protected and promoted and supported during emergencies as well, and that is optimal feeding. And then finally, the 6th action is to take steps to minimize the risks of artificial feeding, and that is primarily around ensuring that donations of products, especially infant formula, don't cause additional harm. So that guidance is available online, and for anyone responding in any emergency setting related to infant feeding, the guidance should be downloaded and reviewed, and that should form the basis of your response. Breastfeeding is an emergency preparedness activity. We don't always think about it that way, but it is very much so. Breastfeeding is also emergency protection. So when you're in the midst of your crisis, breastfeeding helps to protect that population. And breastfeeding is food security. The breastfed infant is in a food secure position, and the infant that is not breastfed is in a food insecure position. These are sort of the fundamental tenets that we're considering as we're looking at how we respond. So we're going to shift gears now a little bit and talk about specific communications. There is an excellent resource also from CIRC that is the communications model for responding in an infectious disease outbreak. And there are 6 areas of guidance, and I encourage you, if you're responsible for preparing messaging or for supporting your communications folk within where you work or within your sphere of influence, to go ahead and access this fact sheet, download it, and take a look at it and have it handy. The 6 principles are to be first, so to be in fast with information, because people, when they don't understand much about a situation, they tend to be very open to information initially, but then sometimes it's hard to change their mind if the first information they received was inaccurate. And so you need to be accurate. You need to be right, and you need to be credible. You need to be trustworthy. They need to be able to know that what you're saying is important, especially if they don't have time to be able to evaluate for themselves. It's important to express empathy. It is clear that people want to be able to know that their particular situation is understood. You need to promote action. We don't just tell people what they should know. We need to tell people what they should do. Action-oriented communication is very important, and it needs to be respectful. This is evidence-based communications theory that is prepared for us in a succinct way for us to understand and remind ourselves of the basics of communication during emergencies. So infant and young child feeding specific to a pandemic response. It is important for infant feeding experts to be at the table when we're planning our response, to make sure that all of the scenarios that are being considered and the recommendations that are being made are specific to the needs of all of our vulnerable populations, and including our populations of pregnant and birthing families and families supporting young infants and children who have specialized feeding needs. We also want to make sure that we are looking at our existing infant and young child feeding programming so that we can address and action any changes that need to be made related to social distancing, for example. Those needs are going to change and priorities will change, and adaptation to programming has to be considered. It's not good enough to just cancel programming while we're waiting for the emergency to end. Babies, of course, don't wait to be born, and their feeding needs are emergent. And wherever possible, we want to be assessing what changes are necessary to existing feeding practices, and we need to consider whether or not we need to make changes to our available supplies. So I'm going to review in the next couple of slides and give you just a little bit of more specific information about how to consider when you're asked or when you need to communicate, what you need to do to develop messaging, how you might adapt existing communications that you already have related to lactation or infant feeding, and how you want to consider the key protection messages that are being sent out to your general population, and what changes you may need to make or additions you may need to make for this particular population. So in general terms, the general population, messaging always begins with awareness, and so when you're looking at your organization or your government's overall messaging, they're focused first on the general population and the most broadly impacted population, and then you'll notice, of course, that they move down and start speaking to more specific populations or audiences. And so it's our responsibility as infant and maternal health workers to listen and to think through the lens of, or look at the lens of what our families who are most impacted related to infant and young child feeding are going to be hearing, and whether or not there are more specific or targeted messages that are needed for that audience. After awareness, prevention messages are key, and those messages then need to be targeted to the more vulnerable populations and those who are specifically impacted. And we also need to consider that the audience is not just the population impacted, but we have workers who are supporting that population and others who are supporting that population, and there may be some very specific messaging there. So for example, the messaging that you have for families may be different or it may not be as complex, or it may be simplified from the messaging that is delivered to a healthcare professionals working in a hospital setting. And then thirdly, the response messages. These are messages that you send where you want people to respond to your message and take very specific, direct, and sometimes extremely timely action. And so the audiences are again segmented, and they tend to be the same audiences: your vulnerable or your impacted population, your workers, and people who support them. But you're increasing your focus around action that you want people to take. So when you are, and the resource for that, I'll just flip back for a moment. There's a good resource on Relief Web that was compiled by the Pacific Humanitarian Protection Cluster. It can easily adapted for a more general audience, and I think it's an excellent resource. So I encourage you to explore that, and further, if you need some help in figuring out how to begin to develop and adapt and communicate messages for this particular audience. Now, how do we determine our audience for our key protection messages specific to COVID-19? So first, again, looking at this general piece, your affected community is this big, long, large circle, and this circle is all of us, everyone. Within that is our vulnerable population. So in our particular case, our vulnerable population are the infants and young children and the caregivers who provide for them, and also the families who are preparing to receive them, so pregnant and certainly late pregnant people. And then within this large general affected community, where we're all typically receiving, we're on the receiving end of messages, we have more specific people that we are targeting messages to, and so those would be the workers. So we have, of course, our vulnerable population, and then we have the workers who serve them. And in this particular case, we are very broadly identifying healthcare workers, and then emergency authorities. And in a pandemic emergency, the emergency authorities are often, but not always, are health authorities. And certainly when those of you by now are probably used to seeing daily updates from your government authorities, it may start with someone very senior, like the Prime Minister of your country or the Premier of your province. But very quickly you will see that most of the messaging comes from the health authorities. And then the third targeted audience there is our peer or community support people, and that can be anyone from healthcare workers who are volunteers, or peer-to-peer support, or families and other people within the community that support in general, who may be needing to receive messaging around supporting families with infants and young children. So to go back here to the audience piece, when you're determining your messaging, you want to think about your audience. It's really important to make sure that you're communicating specifically to the audience that needs to hear the message, and not trying to send out a general message to a general community when what you really want is for your families to hear the message, or your pregnant people to hear the message. So the key takeaway here in determining who your audience is for protection messages, and I have a couple of examples. We're going to drill down a little bit into the specific vulnerable population audience and segment it a bit further. But before we go there, you want to be specific in your messaging. So ask yourself the question first: who is this message for? And then in your messaging, if the message is for pregnant people, say that. So this is an example of 3 social media messages that have been prepared in the past by SafelyFed Canada for people impacted by a pending hurricane. So this particular message on the top left, it's targeted specifically at someone who is about to have a baby. This message over on the right, this is specifically targeted, and you can see from the visual image that we're targeting healthcare providers. And then the message at the bottom is someone who has just birthed. So you might ask yourself, why do we need to differentiate between someone who's having a baby and someone who has just birthed? The more specific you are in identifying your message, the easier it will be for your message to resonate for the people you're targeting, and you'll be less likely to confuse or concern people who aren't the target of your message. So identifying your vulnerable populations specific to families, you'll be looking at targeting late-term pregnant people. You'll be targeting then those who have birthed, so those with newborns who are much more likely to be exclusively breastfeeding or need to be supported to be exclusively breastfeeding. And then if you think about the age of the infant as time goes on, we know that breastfeeding exclusivity declines. And so now you're going to be thinking about those people who have infants that are a little bit older. They may still be fully breastfeeding or they may be partially breastfeeding. What are the messages that someone who is feeding an infant who's only a few days old needs to hear, and what is the message that someone who's feeding an infant who may be 3 months old and is only being breastfed once or twice and is being fed infant formula for the rest of the time? And then finally, of course, the people who are not breastfeeding or infants who are not being breastfed, that is another separate target for specific messaging. If we focus on the audience for the messages, we are less likely to get pushback around our messaging. We know there's a lot of confusion about messaging, and in particular, in the midst of a crisis is not the time to generally tell the population that breastfeeding is important, but rather you want to speak to people in terms of where they are in their breastfeeding journey. You want to be direct. So what do you want the late-term pregnant person to do? What do you want someone who is not breastfeeding to do? And consider the why. You'll notice that in these 3 examples that we've given, the why is not in the image, but the why is in the detailed information that accompanied these messages. It's important for people to know why. If the message resonates for them, they may already know why. That's why it resonates. But if the message is confusing or new or surprising to them, they'll want to dig in and they'll want to learn more. And so you'll want to make sure that you have some layers of information to provide to them. So the next section I'm going to turn over to Michelle now, and this is the section that is much more specific to COVID-19. Go ahead, Michelle.
Thanks, Jodine. So in this section, we'll talk about what COVID-19 means for adults as well as the pediatric population, and then look at how it affects both breastfeeding promotion and support programs as well as implications for non-breastfed infants and complementary feeding. And we'll close off with workforce considerations. So in terms of breastfeeding during a COVID-19 infection, we have at this point a reasonable amount of data, and the WHO issued interim guidance in early March that includes the instruction that breastfeeding can continue during a presumed or confirmed COVID-19 infection. This is worth noting, particularly in places where testing is not as widespread. For many people, anyone who's experiencing even mild symptoms that are pretty vague, so fever, cough, runny nose, are being presumed to have a COVID-19 infection. So it's really quite important that group can actually be quite large within a population. The CDC guidance is aligned to that, except that it also considers separation of the dyad at birth if the mother is infected. And in general, what we're seeing on a consensus basis is that where COVID-19 infection is suspected, we're encouraging basic good hygiene, distance from other family members where possible, and general protective measures are encouraged. And many local organizations are using their seasonal influenza guidance to guide parents on that. So in terms of what we know about COVID-19 infections in the perinatal population, we don't have a lot of data on infection in pregnancy or children. What we generally know is reassuring, but it's worth noting that this information is still very much on an interim basis, and as more data comes in, the picture becomes more and more clear. What we do know quite clearly is that breastfeeding is protective against respiratory infections generally, and we also know that respiratory infections are not readily transmitted through breast milk. So with other viruses that cause respiratory infections, we typically don't see that they transmit very readily through breast milk. And finally, typically healthy adults who are under the age of 50 tend to fare fairly well. With that, it's worth noting that even though healthy adults who are under the age of 50 tend to fare quite well, versus older adults who are over the age of 50 and particularly over the age of 70, the impact to the childbearing age population is still quite a lot more severe than we would see with typical seasonal influenza. So while much of the message has been this is a concern for older folks, we really need to consider as maternal child health workers that we're likely to see a pretty significant impact, which is more significant than what we see with a seasonal flu, for example, in our population. What does that mean for infant feeding and young families? Well, one thing is that we need to ensure that we're giving parents, their supporters, and healthcare providers access to the key messages that are carefully honed to the specific audiences and carefully honed to the local conditions, as well as supports. So messages need to be matched with the available supports. So telling people to do something that can't be done because the services aren't available to them is not helpful. So we want to make sure that there's a match there. We need to recognize that new families typically are accessing the healthcare system a lot more frequently than they have prior to the birth of their children, and that this is going to be complicated by the fact that there are going to be stresses on the healthcare system as well as other crucial infrastructure within our communities. So at a time when new parents are expecting to have lots more contact with the healthcare system and other kinds of social services systems, those systems are going to be under a lot of stress and focusing resources possibly in other areas in order to meet the needs related to the pandemic. And finally, disruptions in school and daycare are likely to create extra challenges for families, and particularly for women who are often the primary caregivers within their families, as well as who are often the caregivers when family members, including extended family members such as grandparents, fall ill. So what we know right now for COVID-19 infections that occurred during breastfeeding, breastfeeding can continue through the infection where parents are separated from their babies either because they are too ill to breastfeed directly or because they've been admitted and are separated from their infant. The current advice is to express that milk and feed it. If parents are infected, both parents and caregivers should be practicing general good hygiene, washing and masking when with baby, including during breastfeeding. So those are sort of the general pieces of advice that are pretty consistent across various public health bodies. There is a question mark around the use of masks and the use of separation during breastfeeding, and one of the pieces of that is whether or not that equipment is going to be available. So when we get that question, what we're answering right now is that the advice should be implemented to the best ability possible. So a single parent who has a mild COVID-19 infection and has no one else to look after their baby may not be able to stay away from their baby most of the time. Someone who is at home and becomes sick and is in a place where masks are not readily available may not be able to do the masking procedure as suggested. So we're doing the best we can with what's available to us at the time. So the key messages that we're recommending at this point is if someone is pregnant, breastfeed your baby even if you didn't plan to. So for parents, typically infant feeding plans are set in the prenatal period. For some parents, they plan to not breastfeed because of a prior experience or because of their own values or decisions. The recommendation right now would be to continue to attempt to breastfeed their baby for as long as they can, even if they didn't plan to. They don't need to continue that indefinitely, but certainly that they should start out breastfeeding if they can. focus their plan on their birth plan on getting breastfeeding off to the best start. So really, while they're pregnant, giving some thought to how they can get breastfeeding off to the best start, talking to their physician, talking to their midwife, talking to their doula, or other support people to get breastfeeding off to the best start by having early skin-to-skin contact, early feeds, and encouraging on-demand feeding, on-cue feeding during their hospital stay. Parents who are breastfeeding, the general message that we want to give them is keep breastfeeding. It's safe and protective. And for parents who are ill, those parents who are ill with COVID-19 or any other infection are going to make an individual feeding decision based on their particular circumstances and their particular condition at any given time. But generally speaking, we're talking about keep breastfeeding and it's safe and protective. For parents who are at the point where they might have intended to start introducing bottles or introducing some formula, either because they're going back to work or to school or just because they'd like to, we're going to encourage them right now to not stop breastfeeding and to wait to introduce bottles and formula. And for many parents, particularly past the first couple of weeks, they are doing something we call mixed feeding, which is they're breastfeeding some and they're bottle feeding some, or they're using formula for some. If it's possible, we're asking them to continue to increase the amount of breastfeeding they're doing. For some parents, that's not possible. For some parents, it is possible. And for those parents where it is possible, that's going to be the recommendation. For parents where exclusive breastfeeding is not an option, we're going to encourage them to practice the best hygiene they can. So parents who might not typically sterilize bottles and feeding equipment, we're going to recommend that they do. For parents who might typically not necessarily think about washing their hands or might use a bottle that's been out for a little bit longer than an hour, we'll really encourage them to go back to those very best practices around sterilization and hygiene. That's particularly true if there's an infection in the home, but it's good advice across the board. And it not only helps us to reduce the risk of transmission of COVID-19, but also helps us to reduce the general risks that these babies face. So we're not just talking about reducing COVID-19 infections, but we're also trying to reduce the number of other infections like gastro infections, respiratory infections that these babies are getting so that they don't end up in an overstressed healthcare system. And for those parents, we want to encourage them to have about 4 weeks of formula or donor milk on hand, which is a little bit more than most families may have. And finally, for all families, we're encouraging them to think about preparing for a prolonged period of isolation. So to have four weeks of what their family needs to be comfortable and well, and that for young children includes not just infant formula if they're using it, but also the snacks that they're using it if they're over 6 months, that they're using over 6 months, diapers and wipes if they're over 6 months, or if they're still using diapers, those sorts of things, and also having plans for daycare and other caregiving if parents are unable to offer that over the long term. So those are the pieces that we're thinking about when we're planning our communication out to the public. But many of us also are managing active programs for young families. So a couple of the considerations that you want to keep in mind. One is that screening procedures are really changing very rapidly. So from the time we first started doing these briefings to today, the screening procedures at hospitals and doctors' offices and other other programs has really changed quite a lot. Initially, in Canada, we were only dealing with a limited number of travel locations, and today, and not really focusing a great deal on symptoms. Today, we've shifted much more to a symptom-based screening as opposed to necessarily a travel-based screening. Keeping in mind that staffing and so when it comes to screening procedures, really keep in touch with your local public health authority and stay aligned to their recommendations, as well as the recommendations of any infection control or risk management staff that you have within your facility or organization. For staffing, from a staffing and facilities perspective, it's likely that COVID-19 is going to affect both of those pieces. So facilities in much of Canada are closing, and much of the world are also changing their hours or shuttering completely. And staffing is being called into other priority areas and also being quarantined or being pulled out in order to protect them for isolation. That being said, families are going to continue to need support, and the needs are going to be uneven across populations. So for some families, it's going to be very easy to just kind of give up the weekly support group. For other families, that weekly support group is really a lifeline and really critical. And there may be new supports that are needed. Families who have new babies are no doubt experiencing increased anxiety around the world. And for some families, that may tip them into really needing some mental health supports that are more formalized than they might have otherwise been. And finally, making sure that we coordinate with our other service providers to ensure that basic needs are met. So we create pantry lists to make sure that all parents and all families know what they need to prepare for an extended period of isolation, but not all families are going to be able to actually go out and purchase those items. So making sure that we're coordinating with other services to ensure that those basic needs are met for every family and every baby. So a few suggestions that have been rolled out in various places. One is certainly to use virtual options wherever possible, so to reduce contact between staff and parents, and also among parents. Phone and text support, so organizations in Ontario, for example, like Breastfeeding Buddies and Breastfeeding Companions already do telephone support, so they have volunteers who are ready and trained in that telephone triage. Online meetings, so Lactation Canada and other groups globally do online meetings where they use Facebook or other platforms to meet virtually with families. And in some cases, one-to-one video calls or the use of telemedicine services can be very effective. Where interperson contact and isolation is not as tight, it may be worth trying to create smaller or staggered groups or using larger locations so that there can be more distance and space between people who are coming in. The other thing to consider, particularly for practical supports for individuals who really need practical supports like food bank or diaper banks, those sorts of things, having a no contact pickup option or having even delivery of critical items may be something to consider. In terms of the workforce, the aim is to reduce exposure to keep workers healthy while making sure that we're offering the services that keep all people healthy. We can expect globally that there'll be a diversion of healthcare workers to life-sustaining essential services. And what essential services means is really determined not by our own view of whether or not what we do is essential, but by the public health authorities and sometimes the civil authorities more broadly. One of the things to consider in terms of workforce is the availability of personal protective equipment as well as the training and use. So there is a significant amount of advice out there to use things like masks and gloves and gowns, but not necessarily the training in place to make sure that those masks and gloves and gowns are being used appropriately. One of the other pieces to keep in mind is that while telemedicine and phone triage can be really effective ways of meeting the needs of large groups of parents, it has a bit of a learning curve. So knowing how to use those telemedicine services as well as having training in how to do appropriate phone triage is something that needs to be built in. And also keeping in mind the demographic of the workforce serving maternal child health. So depending on where you live in the world, many of the workforce, or the majority of the workforce, may be either older, so at greater risk of COVID-19 infection, more requiring more isolation in order to keep them safe, or many of them may have young children who now need more care at home when schools and daycares are closed. So that's something where you really need to know the community that you're serving and who your workforce is. Speaking of personal protective equipment, there are already reports of shortages of personal protective equipment globally, so making decisions about which workers need to have access to that, what level of equipment they need to have, and how we allocate that is going to be a very local decision, but it's certainly one that needs to be considered. Over the longer term, there are some concerns about getting supplies in, particularly as some of our healthcare systems start to shift a lot of their attention to personal protective equipment and other kinds of equipment, whether or not we'll have the appropriate supplies and supply chains to get those supplies such as pump parts, lactation aids, those sorts of things. And finally, one of the questions that's already arising, I think, in many areas in North America, and we've also had reports from Europe and Australia, is around the availability of infant formula and commercial baby foods. We have heard of local shortages noted across Canada, although there is no interruption of supply or production that's specifically been flagged yet at this point. So at this point, we'll just talk a little bit about the resources and information gaps that we have at this point, at this stage in the pandemic. One piece that I'd really like to underline for all of you listening is that folks who work in maternal child health have a lot of the skills that are necessary already in their toolkits to help parents weather this storm and to help support the healthcare system and social services systems to ensure that our most vulnerable babies and their parents are protected. In terms of high priority skills in areas where we see that we'll need lots of folks who are skilled in this area, around telemedicine, virtual support, and telephone support and triage is something that's going to be really important over the next few months. Relactation and induced lactation. So for parents who stopped breastfeeding prior to the pandemic, who are now deciding that they'd like to return to lactation, either because they feel that they want that immunological protection for their baby, or because they're concerned about being able to have a reliable supply of food for their baby. There are a lot of reasons why they might do that. So those skills are going to be very important. As Jodine related earlier in this session, the concern around prenatal breastfeeding counseling. Parents do make the decision about whether or not they're going to breastfeed during their pregnancy, during the third trimester typically. And so we really want to make sure that we're giving them good counseling that's based on the circumstances that are currently happening in our particular area, and have the skills to really give them, to help them build that confidence and that self-efficacy for when their baby is born. Breast milk substitute hygiene. So in many parts of the world, certainly I think in my part of the world here in Canada, our hygiene practices around the use of breast milk substitutes are not as necessarily as strong in practice as they might need to be. So we may need to be doing some extra teaching around that and really making sure that we're very clear around what kind of hygiene level is required, particularly in this situation. And finally, the last two pieces are around translation of emerging research and the development of evidence-based interim guidance. And particularly because this subject is moving so quickly and it's of such critical importance to families and to healthcare providers, folks who have the ability to really take that emerging research and make it into something that's useful to people, as well as to translate that research into guidance that can actually be applied either at the home level or at the clinical level is really critical. So those are kind of high priority skills in areas where I think that many of us in maternal child health already have those skills, and we can build those skills and come together to maximize them. So pandemic response is built on a global consensus, but it's delivered based on local circumstances. And that's really, if you take anything away from this today, I'd really encourage you to think about the fact that we're going to be drawing from the global consensus that's built on the data and the evidence that we have from all around the world, but ultimately we're delivering this one parent and one community at a time. And I'm going to let Jodine pick up the rest.
Yes, thank you, Michelle. There's just a couple slides left. So this is a selection of resources that we have brought together for you. The first resource is one that we are preparing and updating routinely. And what we've done is we've gathered credible, typically global or significant resources related where there is specific advice or guidance that is given related to infant feeding and lactation. The IFE Core Group Operations Guidance, which I referenced earlier, is version 3. Make sure you have version 3 from 2017. It's available in a number of languages, and there are some very good specific pieces there that are helpful to you, and also it is very well referenced. The International Lactation Consultant Association is also preparing a compilation of resources for IBCLCs. Also has excellent guidance and is updated consistently. There's also an organization, GTAM, the Global Technical Assistance Mechanism for Nutrition, which has a broader technical brief that is available related to nutritional needs during this pandemic, and there is a section in there on lactation. And there are many other resources. I think that we certainly welcome additional resources if you have one that's good that you'd like us to include, and if you have concerns about a resource or if you're aware of resources that may not be aligned with global guidance, we'd be happy to take a look at those for you as well. Please do reach out as we're reviewing resources on an ongoing basis. Finally, we just want to leave you with a couple of areas where we know that there are some questions that are emerging and also where we know there are gaps. So in particular, the issue of whether or not the dyad should be separated at birth or when there's a need for healthcare service or hospitalization, say the birthing parent becomes ill, quite ill for whatever reason, including COVID-19. What we are seeing is that there is some guidance that is quite specific and calls for separation of the dyad when there's a concern about COVID-19 infection, confirmed cases or possible cases. And then other guidance, in particular our World Health Organization guidance and some of our obstetricians and gynecologists colleges in various countries are suggesting that that separation should be on a case-by-case basis, and in general they're wanting us to understand that the separation comes with risk and that the risk of interrupting breastfeeding has immediate and lifelong health impacts for the dyad. So this is an area we continue to watch carefully. The next emerging question or gap is related to, and this is a gap, we're not seeing enough good guidance for families that are supporting, or caregivers that are supporting the non-breastfed infant, in particular related to practices, hygiene practices. And at the end of this list, Michelle, please jump in if I missed any of these points. And actually, Michelle, I'll let you take over these next couple of pieces because I know that I'm going to ask you again to remind me what PPE stands for. So please jump in.
Hi. So as I noted earlier on, the appropriate use and provision of personal protective equipment in clinical and home settings is a big question. And this is going to vary based on local availability as well as prioritization and caseload size in hospitals and other clinical settings. So we are currently using the global consensus guidance, which is to mask and wash hands when breastfeeding with a COVID-19 infection. But the guidance for personal protective equipment for healthcare workers in general, as well as in a home, for example, in a home setting, it isn't established on a consensus basis. And the big question there is if there aren't enough masks, where should we be using them?
Right.
And then finally, the maintaining adequate resource allocations for breastfeeding and other preventative services. So all of our healthcare services, I think right now globally, it's safe to say, are really focused and zone in and honing in tightly on what they need to do to respond to COVID-19. But we also need to keep in mind that maintaining resources in place for breastfeeding, as well as other preventative services that both families and others in the community require, reduces the load on the healthcare system ultimately, and particularly with breastfeeding, it's not easily reversed. So if we lose breastfeeding in certain families because we didn't have adequate supports in place, it's not so easy to go back and regain that lost breastfeeding, which has a lifelong impact on that dyad. So those pieces are really questions as we move through, and are going to be are really going to require us, as we said at the beginning, to make sure that infant feeding experts are at the table when those decisions are being made around resource allocation.
Right, and I'll just jump in there and add that the new WHO guidance, which just came out a couple of days ago, is very specific and very clear in reminding us that the dyad needs to receive, that families need to receive practical support, and I'm quoting now, to enable them to initiate and establish breastfeeding and to manage breastfeeding difficulties, including infection prevention and control measures. So this is really specific to COVID-19, and it's a reminder that we are not setting this need aside in the midst of this pandemic. It goes on to say this support should be provided by appropriately trained healthcare professionals and community-based lay and peer breastfeeding counselors, and then they cite counseling guidance. So it's just helpful sometimes, I think, for us to be reminded that our global guidance is asking us to continue to work to the best of our abilities to support breastfeeding through this crisis.
Thank you so much, Michelle and Jodine, for an excellent presentation, and I hope that the information is helpful to everybody who is seeing or viewing the presentation that will be made available for you all. It takes all of us to make a difference, so wishing everybody to be safe. Remember to wash your hands. And again, thank you, Michelle and Jodine, for an excellent presentation.
Thank you for having us, Carol.
Thank you.